Welcome. You will now see and hear a presentation about poliomyelitis, the after effects, and the post-polio syndrome. General introduction. It is of initial importance for you to be able to understand how our central nervous system works in reaction to polio, in order to realize the implications regarding the after effects and the post-polio syndrome. If you are a polio victim, you may be able to slow down the degeneration and counteract many of your ailments once you have digested this presentation. The information in this presentation is helpful for polios, doctors, nursing staff, and those directly involved with polios, i.e. relatives and friends. For some, this presentation may seem very technical to start with. That is why we shall be repeating some of the medical explanations and terms as we proceed. By the time you reach the end, you may be familiar with your own nervous system and PPS, and probably be able to pass on general information verbally with ease. Main topics introduction. Poliomyelitis. Polio, also known as poliomyelitis or infantile paralysis, is caused by a highly infectious virus. Polio can be potentially fatal. On infection, the poliovirus generally attacks the nerve cells, alpha motor neurons, particularly those in the spinal cord that carry messages, electrical impulses, between the spinal cord and the muscles in order for them to function, and can cause severe muscle paralysis, paralytic polio, including severe damage to nerve cells in several control centers of the brain. Each motor neuron consists of three components: the neuron body, control center, numerous smaller branching fibers called dendrites, and a major branching fiber, nerve string, called the axon. The end fibers of an axon innervate destined muscle fibers. After effects of polio. The outlook depends on the form of the disease and the body area affected. If less than 50% of the spinal cord and brain neurons are involved, which is the case with more than 95%, then a seemingly full recovery is likely. About 1% or less of polio infections may result in paralysis or death, the latter usually due to respiratory problems. Many patients who suffer the paralytic form recover, but some complications may remain, such as bone deformations, muscle atrophy, flaccid paralysis, bulbar, respiratory problems, etc. A polio infection often leaves many motor neurons destroyed or irreparably damaged. To compensate for the resulting shortage, the remaining neurons sprout new fibers, enlarging the surviving motor neurons. This promotes some recovery of muscles, but places additional stress on the neuron body to nourish the additional fibers. Post-polio syndrome, PPS. PPS is a condition that affects polio survivors approximately 15 to 40 years after recovery from an initial acute attack of the poliomyelitis virus. Some experts reckon from 10 to 40 years. The general accepted theory is that over the years, the overstressing, overload, caused by the continual compensation and remodeling of new fibers leads to a gradual deterioration of the sprouted fibers that innervate the muscle fibers and, especially, of the motor neuron itself. Central nervous system. Our brain consists of 100 billion nerve cells called neurons. Everything we think, see, hear, smell, taste, feel and do depends on their ability to communicate. All neurons work parallel. Interface with 10,000 or so neurons, they work simultaneously, each one carrying out its own particular part. Brain and spinal cord form the central nervous system, CNS for short. Its function is to interpret, store and respond to information received from the environment outside and inside the body. The spinal cord begins directly under the brainstem, the medulla oblongata, the lower portion of the brain. The 12 so-called cranial nerves originate directly from the brain and not from the spinal cord. They provide the main motor and sensory innervation to the eyes, face, neck, and small parts of the upper shoulder belt. The spinal cord provides the connection between the brain and the peripheral nervous system, PNS for short. Depending on gender and body length, the spinal cord is approximately 45 centimeters long and has 31 pairs of spinal nerves that branch off the spinal cord through intervertebral foramen. Dorsal root ganglia. Each segment of the spinal cord is associated with a pair of ganglia called dorsal root ganglia that are situated on the exterior of the spinal cord and contain cell bodies of sensory neurons, afferent sensory axons, picked up by sensory receptors throughout the body, the PNS, and carried towards the spinal cord and brain, the CNS. Ventral roots consist of axons from motor neurons of the anterior horn, as well as, in some spinal cord sections, fibers of the autonomic nervous system, the ANS. Their cell bodies are situated in the central part of the grey substance and bring information to the periphery from cell bodies within the CNS. The axons of motor neurons, efferent, are carried away from the CNS through the spinal ganglion to form nerves of the PNS that innervate the body's muscles and glands. Alpha motor neurons innervate striated muscle fibers, typically referred to as muscle fibers, which are located throughout the muscle. The spinal cord is a prolonged extension of the brain that is surrounded by fluid and closed in by skin layers similar to the meningeal. The spinal cord is of cylindrical shape and consists of white and grey matter. The grey matter in the center of the spinal cord is shaped like a butterfly and consists of cell bodies of interneurons and motor neurons. Projections of the grey matter, wings, are called horns. The white matter is located outside of the grey matter and consists mostly of myelinated axons that serve as long pathways to and from the brain to the neurons within the spinal cord. The axons of sensory neurons, afferent sensory axons, enter the posterior horn, dorsal horn, whereas the axons of the motor neurons leave the spinal cord via the anterior horn. All conductive paths join in the so-called spinal ganglion to form a nerve serving a specific part of the body. The spinal cord is closed in and protected by various skin layers similar to the meningeal. The brain spinal fluid, liquor cerebrospinalis, flows between the skin layers and the medulla. The central nervous system controls the functions of vital organs of the body and functions of movement and senses, thinking, feeling, and action. It is responsible for processing the complex network of nerves to ensure the organs work correctly. The CNS interprets, stores, and responds to information received from the outside environment and within the body. The nerve cells are called neurons, motor and sensory neurons. They are designed to receive stimuli and to relay them as impulses to other neurons. The nerve projections are called dendrites, short multiple projections, fine protoplasmic ramifications of the cell body, and nerve strings, single long and thin string projections called the axons. The nerve cell, neuron, consists of the neuron body, control center, dendrites and axon. The dendrites receive impulses from other neurons, and the control center of the receiving neuron relays the impulses to further neurons via its axon. The axon is protected by insulating layers called myelin sheaths that guarantee fast transportation of the electrical impulses. The myelin sheaths are separated by Ranvier nodes that enable a constant transportation of the impulses through the axon. The endpoints are called synapses, where the stimulus is passed chemically by neurotransmitters through a microscopic cleft to the next dendrite, the motoric end plate of the muscle fiber, or another organ, meaning a complex communicational exchange takes place between the neurons caused by an electrical and/or chemical process. The interface between a motor neuron and muscle fiber is a specialized synapse called the neuromuscular junction. A motor unit consists of the motor neuron itself and the muscle fibers it innervates. Small motor units support about 100 to 300 muscle fibers and allow a fine force gradation. Large motor units support up to 2,000 muscle fibers and allow only a rough force gradation, i.e. muscle quadriceps. Several axons converge in the so-called spinal ganglion to form a nerve serving a specific part of the body. There are sensory, motoric, and autonomic axons. Sensory axons transfer stimuli from specific organs, eyes, ears, tongue, muscles, joints, and skin. The sprouted fibers of the motoric axons innervate muscle fibers. The autonomic fibers are nerves of the autonomic nervous system, ANS. Axons of all organisms pass information through electrical energy. Let's have a closer look at nature's creation, the neuron with its axon, a minute control center and computer in one. In the center of the neuron is the control center of the cell core, where energy production structures are situated. The nerve extensions are called dendrites, multiple short extensions, and axons, individual long extensions, also called nerve strings. The dendrites receive impulses from axons of other nerve cells and pass them on to the cell core. Here the synaptic end nodes, so-called terminal docking points. The synapse is the terminal junction between various signal transmitter axons, nerve cell strings, either between two neurons or between a neuron and a muscle or gland. Here the pointed oblong cell extension, the axon, also called the nerve string, the neuron exit point for the signal transportation. As mentioned, the axon of a nerve string is usually coated by an insulating myelin sheath. The axon and mark sheath or myelin sheath form together the nerve string of a neuron. Here is an example of a motor neuron and its axon, also called the nerve string, with its myelin sheaths and Ranvier nodes. An axon is usually coated by an insulating myelin sheath, also known as mark sheath. These insulating layers guarantee fast transportation through the axon of substances or impulses. The myelin sheath consists of several fatty insulating layers. The axon and myelin sheath, also called the mark sheath, together form the nerve string of a neuron. There are sensitive, motoric, and vegetative nerve strings. The sensitive nerve strings transport excitations to specific sensory organs such as eyes, ears, and taste. The end fibers of motoric nerve strings predominantly innervate skeleton muscles. The vegetative nerve strings are nerves of the autonomous nerve system, also called vegetative nerve system. The myelin sheath is laced regularly with Ranvier nodes, where the axon membranes are freed. One must imagine the length of the axon of an alpha motor neuron in the spinal cord that has to stretch itself to a particular muscle fiber somewhere in the body. An axon can sometimes be as long as a meter or more, depending on a person's size, for example, from the spinal cord to the large toe. The nerve strings end in synapses, meaning a complex communicational exchange between the nerve cells takes place that are steered by an electrical and/or chemical process. Terminal knob of the axon, the synapse. The synapse is the terminal junction between various signal transmitter axons, nerve cell strings, either between two neurons or between a neuron and a muscle or gland. The nerve impulse reaches the synapse through the axon to its transmitting end. Most neurons have transmitting knobs at the end that respond to the impulse by releasing a chemical substance known as a neurotransmitter. Crossing a gap of microscopic space, the synaptic cleft, the neurotransmitter is freed and contacts the membrane of the adjacent muscle, gland or neuron of branch receptor sites called dendrites. Neurotransmitters include acetylcholine, glutamate, epinephrine, and norepinephrine. These neurotransmitters either excite or inhibit the recipient, depending on the particular reaction between the two. In other words, a neurotransmitter may inhibit activity, i.e. dopamine or GABA, in the postsynapse neuron when attached to a certain receptor, but may excite activity, i.e. acetylcholine, glutamate, when attached to others. If excited, the second neuron transmits the impulse typically to a muscle, gland, or another synapse. An electric synapse, unlike a chemical one, uses channels known as gap junctions to permit direct transmission of signals between neurons. Such synapses are found in the human body, within many organs, and in the glial cells of the nervous system. Electrical synapses are also found among invertebrates and some lower vertebrates. We'll now have a look at how the processing of information through motor neurons via the axon to the destined muscle fibers and muscle cells works. The alpha motor neurons are designed to receive stimuli and to relay them as impulses to other neurons responsible for our muscles through the axons of motor neurons that leave the spinal cord via the anterior horn to innervate muscle fibers. Motor neurons are electrically stimulated. They receive signals from other neurons on the end knobs, synapses, of their nerve projections called dendrites, short multiple projections, and relay the impulses to further neurons via its axon. Electrical energy builds up when a certain stimulus point is reached. This is called the action potential. The neuron transports this energy speedily through its axon. The axon is protected by insulating layers called myelin sheaths that guarantee fast transportation of the electrical impulses. The myelin sheaths are separated by Ranvier nodes that enable a constant transportation of the impulses from Ranvier node to Ranvier node through the axon. An axon protected by myelin sheaths can transport nerve impulses 10 times quicker than an axon without myelin sheaths. The nerve impulses are relayed from the anterior horn of the spinal cord via its axon, nerve string, to the destined muscle fibers. Muscles are composed of many muscle fiber bundles. Muscles are machines that transform chemical energy directly into mechanical energy and warmth. Let's have a look how this works. This is a transverse cross-section of a skeletal upper arm muscle composed of many muscle fiber bundles. In this illustration, you can see the sprouted fibers of the axon innervating muscle fibers. Now a glimpse at a muscle cell of a muscle fiber. The active elements of the muscle cells are the filaments, composed of protein bodies, myosin and actin. On receiving particular nerve impulses, the actin filaments shove into the myosin filaments, producing a contraction of the muscle. The central nervous system, CNS, consists of the brain and spinal cord. The peripheral nervous system, PNS, consists of the spinal cord and cranial nerves. The somatic nervous system, SNS, is part of the PNS that regulates body movement through control of skeletal muscles. It also relates the organism with the environment through the reception of several senses, i.e. sight, hearing, taste, smell, touch, balance, and acceleration, temperature, kinesthetic sense, pain, and internal senses. The autonomic nervous system, ANS, also known as the vegetative nervous system, is the part of the PNS that acts as a control system, functioning largely below the level of consciousness, and controls visceral functions. The ANS affects heart rate, digestion, respiration rate, salivation, perspiration, diameter of the pupils, urination, and sexual arousal. Whereas most of its actions are involuntary, some, such as breathing, work in tandem with the conscious mind. The ANS is divided into sympathetic and parasympathetic nervous system divisions. It consists of nerves in cardiac muscle, smooth muscle, and exocrine and endocrine glands. The sympathetic nervous system aids in the control of most of the body's internal organs. Stress, as in flight or fight response, is thought to counteract the parasympathetic system. There are two kinds of neurons involved in the transmission of any signal through the sympathetic system, pre- and postganglionic. The shorter preganglionic neurons originate from the levels T1 to L2 of the spinal cord and travel to a ganglion, often one of the paraventral ganglia, where they synapse with the postganglionic neuron. From there, the long postganglionic neurons extend across most of the body. The parasympathetic nervous system originates from the cranial and sacral regions of the spinal cord, brainstem and lower part of spinal cord, and generally has a complementary but opposing physiological effect versus the sympathetic nervous system. Its main actions are summarized by the phrase rest and repose or rest and digest, in contrast to the sympathetic nervous system, fight or flight. For the body to be in balance and to be able to respond to appropriate conditions, both the parasympathetic and sympathetic nervous systems are needed to provide their opposing effects. The history of poliomyelitis. Polio infections extend into prehistory. Over millennia, polio survived quietly as an endemic pathogenic until the 1880s, when major epidemics began to occur in Europe. The virus has spread in human waste. It is believed that the general introduction of hygiene in the late 19th century is one of the causes. Less contact, no immunization, more prone to catching the virus. Poliomyelitis is caused by an enterovirus infection that can lead to paralysis or death. The infection spread gradually over the world, reaching the USA. By 1910, polio epidemics became frequent events throughout the world and reached a peak in the 1940s and 1950s, when polio killed or paralyzed over 500,000 people each year. Historical relics show that polio had many victims up to and over 5,000 years ago. Gamma globulin of the blood plasma of polio survivors tested between 1951 and 1952 that contained poliovirus antibodies gave promise of halting the poliovirus infection. But the Salk vaccine, consisting of dead poliovirus carried out in mass vaccinations in the USA, Great Britain and Scandinavia from 1955 onwards, proved more successful. Albert Sabin developed an oral polio vaccine, OPV, using live but weakened attenuated virus. This was tested on humans from 1957 and licensed in 1962. It was only then, due to the persistence of the regional governments of Bavaria and North Rhine-Westphalia, that mass vaccinations were carried out in Germany. The first vaccinations against the extremely dangerous type 1 poliovirus, and in the following years against type 2 and 3, were carried out. Since 1965, the trivalent vaccine against all three serotypes is in use. Up to 1962, the German government was in indecision with the health insurance companies over many years as to who was to pay for the vaccinations. Poliomyelitis, the illness. Polio is a viral infection of the enterovirus family, which means it is a SS plus RNA virus that spreads quickly through the body, attacking muscles and tissue of the central nervous system. Initially, the poliovirus multiplies in lymphoid tissues, tonsils, and intestinal lymph nodes, and then quickly spreads hematogenously throughout the body. As a so-called neurotropic virus, it attacks motor neurons of the brain and spinal cord, alpha motor neurons, and is excreted orally or in the stool. It destroys some of the nerve cells, alpha motor neurons, and their nerve strings, the axons. The corresponding muscle fibers lose contact and are no longer innervated. This results in a flaccid paralysis. Many motor neurons are now destroyed or irreparably damaged. During the recovery phase, surviving motor neurons serving the same muscle sprout new fibers to innervate some of the orphaned muscle fibers that were previously innervated by the dead neurons. While this promotes a certain recovery of muscles, it places additional stress on the neuron body to nourish the additional fibers. The survived motor neurons enlarge, having to support more muscle fibers. These are called giant motor units. This is a repairing mechanism that occurs after the acute polio phase to support paralyzed muscle groups. Poliomyelitis causes brain damage. According to current findings, the polio infection not only affects the peripheral nervous system, but the brain as well. Therefore, the post-polio syndrome is not only a peripheral neuromuscular illness. Clinically more important is often damages to the brain, the encephalic portion, e.g. respiration, whereby the patient is put in an iron lung. Here is an illustration of the poliovirus. The poliovirus and its characteristics. 1. The poliovirus is a fairly simple virus, structurally similar to other human enteroviruses, composed of an RNA genome and a protein capsid. It is without casing, a genome with a single-stranded plus RNA. It belongs to the viral family Picornaviridae, genus Enterovirus, which spread quickly through the body and can cause paralysis within hours or days. Other well-known genera are the Coxsackie A plus B viruses, or the echovirus. There are 3 extremely infectious types of the genus poliovirus. Family Picornaviridae. Genus Enterovirus. Species Poliovirus. 3 types. Type 1, Mahoney or Brunhild, occurs most often, the cause of epidemics and grave illness. Type 2, Lansing. This type has a mild course and was last detected in 1999 in Uttar Pradesh in India. Type 3, Leon. This type is seldom, but generally the course is severe. Wild types are found in Nigeria, Niger, Pakistan, India, and Sudan. Each of the 3 types have slightly different structural capsid proteins. The capsid proteins define cellular receptor specificity and virus antigenicity. The enterovirus are without casing, are small and environment-resistant icosahedral particles that have a positive strand RNA, approximately 7.4 kb. RNA, ribonucleic acid, is a carrier of genetic information that can transform genetic information in a cell into protein. Has a similar structure as DNA. The fairly round virus particle has a diameter of 28 to 30 nanometers. Each particle holds a copy of the single-stranded plus RNA genome, enclosed in an icosahedral capsid. The capsid is composed of 60 copies of the 4 capsid proteins, VP1, VP2, VP3, and VP4. The virus replication takes place in the cytoplasm of the host cell. The poliovirus and its characteristics too. Due to its structure, the poliovirus is an environmentally stable virus, resistant to many commonly used disinfectants, such as 70% ethanol, isopropanol, and quaternary ammonium base. Even with the use of detergents or acid, e.g. gastric acid, the virus can hardly be inactivated. The poliovirus needs a specific receptor to cause an infection, the CD155 protein on the host cells, macrophages, T lymphocytes, and nerve cells. Reproduction takes place in the cytoplasm of the host cell. The virus is spread by smear infection, oral feces, and via objects. After the virus has been absorbed in the mouth, and the reproduction has taken place in both the lymphatic tissue of the nasopharyngeal cavity and in the digestive tract, a viremia occurs, causing the virus to be distributed via the bloodstream. Proof of a poliovirus infection can be made through tests on feces samples, throat swab samples, and brain spinal fluid, liquor cerebrospinalis. Nowadays it is carried out by means of the so-called RT-PCR, whereby viral RNA can be proven. Only parts of the virus genome need to be sequenced. The then sequenced material, humans to humans, can be compared to determine the infection path. A proof of antibodies against the virus can also be accomplished through the patient's serum. According to the World Health Organization and European law, it is compulsory to notify health authorities of a positive proof of a poliovirus infection. The poliovirus and its characteristics. 3. The discoverers of the poliovirus are considered to be Karl Landsteiner and Erwin Popper in 1908. In the 1930s, Armstrong succeeded in transferring the virus to cotton rats. In 1949, Enders, Robbins and Weller were able to reproduce the virus in cell cultures, for which they received the Nobel Prize in 1954. The viral genome was cloned and sequenced for the first time in 1981. Mutations in the internal ribosomal entrance, IRES, are a molecular cause for the weakening, attenuation of polioviruses that are used for oral vaccines. In 1955, an inactivated dead vaccine was developed and licensed by Salk. A few years later, a live oral vaccine developed by Sabin followed. Originally, the virus was spread worldwide. In the tropics, epidemics occurred throughout the year, in the moderate latitudes mostly in summer. In the epidemic disease areas, the virus is also to be found in sewage. In an open environment, the virus remains reproductive for several weeks. The only well-known carriers are humans and anthropoid apes. Currently, the virus is endemic in Africa, a wide range from the Gold Coast to Somalia and South Africa, as well as India, Pakistan and Afghanistan. Course of infection. The incubation period is usually 5 to 14 days, starting shortly after the beginning of the infection, with virus production briefly in the throat, then in the bowels. Approximately 95% of the infections occur without any symptoms. Approximately 5% of the infected have fever, nausea, sore throats, muscle pains and headaches. Approximately 5% of the infections occur like a summer influenza. Approximately 1 to 2% of the infected have a non-paralytic poliomyelitis, with fever, neck stiffness, head and backache. Liquor shows meningitis, but only requires symptomatic treatment. Approximately 0.1 to 1% of the infected have the paralytic form of poliomyelitis. Infection of the central nervous system with aseptic meningitis. Flaccid paralysis. Approximately 80% of these retain a paralysis. Approximately 10% of the cases heal without apparent consequences. Approximately 10% of the cases are deadly. After many years, can lead to a post-polio syndrome, PPS. The post-polio syndrome, PPS. PPS is a neurodegenerative illness. Numerous theories have been proposed to explain PPS. The most widely accepted theory, based on medical studies, of the mechanism behind the disorder is neural fatigue that seems to lay in the destruction of the remaining motor neurons due to overstressing, overload, over many years. The reason being for this lies in the continuous additional stress on the remnant neuron bodies, giant motor neuron units formed after the acute illness, triggered by the physical and metabolic stress, high accumulation of excitatory neurotransmitters to support and remodel the additional fibers that have been supporting more muscle fibers. Other causes that have been proposed by medical experts, whereby the evidence supporting these theories are extremely limited, as follows: a persistent infection of some kind, or environmental chemicals, etc. In this presentation we shall stick to the overload proposal, which appears to be the most general cause. During the phase of functional stability, a continuous dysfunction of alpha motor neurons can be determined. According to current knowledge, once a certain threshold, destruction of more than approximately 50% of the alpha motor neurons, is exceeded, then this results in a decompensation of the de- and re-innervation process that was started after the acute phase of polio. The decompensation is pre-programmed, because under normal everyday conditions, the damaged neural structures are already working on or over their upper load limit, and it is only a question of time, depending on the initial damage and the height of the overload. Healthy nerve strings, axons. Signals for determined, i.e. arbitrary muscle movement, are transported through motor neurons. Their associated long nerve strings, axons, are bundled with other axons and run from the spinal cord to the muscle fibers of the particular musculature. The sprouted fibers of the axon innervate the muscle fibers. Acute polio infection. The alpha motor neurons infected by the poliovirus are dying. All associated muscle fibers are paralyzed. The remaining intact axonal sprouts innervated in the muscle fibers are marked blue. The recuperation phase after the infection. Newly sprouted axonal fibers are marked in red. This means that axons in the vicinity of the dead axon or axons develop additional axonal sprouts to innervate, meaning compensation of the abandoned or rather destroyed axonal sprouted fibers. Compensation remodeling 1. Remodeling means that motor neurons, which formed new bypasses in the recovery phase, now serve many more, or rather multiple, muscle fibers than before. This is defined as a giant motor unit. This adjustment is not static, meaning old bypasses are being constantly replaced by the regeneration of new ones. Compensation remodeling 2. One theory maintains that muscle cells thicken through regular training after the recovery phase and therefore get stronger. The two compensation mechanisms, muscle growth and improvement of neural support by the increase of additional axonal sprouting, are very effective. Clinically seen, 50% of all motor neurons can be lost without a decrease in normal muscle power. However, the adjustments are neither static nor durable. The fact is that after recovery from the acute infection, the giant motor units are remodeled continuously. Old synaptic contacts phase out, whilst new synaptic contacts are generated. The dynamics of a permanent repairing mechanism are based entirely on the constant use of physical power. A renewed muscular weakness will occur if the equilibrium between reduction and build-up is disturbed. The degeneration path, post-polio syndrome, PPS, regeneration phase. More than approximately 95% of all spinal cord motor neurons and many brain cells can be stricken by the polio infection. Some of them recover later on, and others die. The human organism can compensate partly for the loss of some motor neurons, but to what extent a paralysis remains cannot be foreseen. This is due to an inexplicable stimulation factor. Numerous motor neurons that survive are able to make contact with abandoned muscle cells, whereas the abandoned muscle cells would otherwise degenerate. It is as though the body wants to keep as many of the muscle fibers that were uncoupled from the central control alive and functional. In the end, such a motor neuron that originally had innervations with perhaps 100 to 2,000 individual muscle fibers makes contact with 3,000, 5,000 or even 10,000. During the recovery phase and thereafter, the few surviving motor units take over the work of many of the abandoned motor neurons and form giant motor units. However, the remaining motor neurons work on a continuous power limit or even above, as if they were participating in a lifelong marathon race. Degeneration PPS. After many years, approximately 15 to 40, of a certain stability of body functions, the giant motor units start to degenerate. The consequences are a renewed muscle weakness. Degeneration means that losses are greater than the regeneration can cope with. Only the blue and green sprouted fibers have survived. PPS possible causes. The thesis that a creeping degeneration of the sprouted fibers is involved in the PPS finds general acceptance. This was already suggested by Wiechers and Hubble from the State University of Ohio in Columbus in the early 80s. According to their research, they found out that during an advanced number of years after the convalescence period, the motor neurons of polio survivors increasingly lose their functional abilities. The classification of the post-polio syndrome. Currently, PPS is classified as an independent disease, secondary illness. It possesses its own index G14 within the worldwide ICD-10 definition, ICD meaning International Classification of Disease. In this respect, it is distinguished, defined by the World Health Organization in relation to all other aftereffects of polio. See Index B91. Diagnosing the post-polio syndrome 1. The diagnosis of the post-polio syndrome PPS is based essentially on a detailed anamnesis, a thorough medical examination, including a neurological and orthopedic status. There are no existing laboratory tests that give diagnostic proof. The diagnosis of PPS is always an exclusion process, which does not as such give proof. Contrary endeavours in daily practice only prove the lack of specific knowledge of physicians. Differential diagnostic examinations and laboratory procedures can be of diagnostic help. Computed tomography (CT), magnetic resonance imaging (MRI), electromyogram (EMG), ultrasound, histology, and laboratory tests could be useful in the determination process. Muscular stress can often be recognized by an increase of the CKMM activity in serum. CKMM is the muscle enzyme creatine kinase. Diagnosing the post-polio syndrome 2. The following indications give helpful references for a PPS diagnosis. However, they are not proof. A history of polio is indicated in the anamnesis. After the acute illness, an improvement occurred. A stable phase of at least 10 years followed. Acute or new ailments start to creep up, or general deterioration, i.e. on minimum activity, abnormal fatigue and exhaustion occurs. New muscular weaknesses and muscular atrophy. Progressive muscle, joint and nerve pains. Unusual temperature intolerance, especially cold intolerance. Problems swallowing and sleep-related disorders, nocturnal sleep apnea. Problems after an anesthetic, especially if the polio illness was not considered when the type of anesthetic and dose was applied. The neurological examination is compatible to a preceded poliomyelitis. All other diagnostics as an explanation for the new complaints can be sufficiently excluded. Symptoms of the post-polio syndrome. Health problems in percent of the polios concerned. Tiredness, 85%. Muscular pains, 80%. Joint pains, 80%. General weakness. In previous stricken muscles, 80%. In muscles not previously stricken, 60%. Cold intolerance, 45%. Atrophies, 35%. Activity problems in daily life. Walking, 75%. Climbing the stairs, 70%. Getting dressed, 40%. Other symptoms. There are many other symptoms such as urinary or bowel problems that may not be related to PPS. When other possible causes are ruled out, PPS is sometimes thought to be the case. When does the post-polio syndrome occur? PPS manifests itself usually 15 to 40 years after an endured poliomyelitis in an acute or creeping form. It often begins with new weaknesses in muscles where muscle contraction occurs repeatedly, e.g. when walking, climbing the stairs and/or dressing. The weaknesses can also apply to muscles that were apparently not affected by the acute poliomyelitis. Breathing problems often arise for the first time in conjunction with an anesthetic. In most cases, patients are treated with painkillers or other medicines, as most doctors or patients don't attribute the current status to the original polio illness. Physical therapy, muscle building training, is very often prescribed, which is more harmful than helpful for the patient by speeding up the degeneration process. It is presumed that PPS is caused after the initial acute polio by the systematic overload over many decades of the few remaining motor neurons, which perish irreversibly one after the other. As PPS cannot be healed, it is therefore most important to accept the status by taking it into consideration and changing and fitting the new situation into an entirely new way of life. Factors that increase the risk of developing PPS. Severity of initial polio illness. The more severe the initial infection, the more likely there will be signs and symptoms of PPS. Age at onset of initial illness. If polio was acquired as an adolescent or adult rather than as a young child, the chances of developing PPS increase. Recovery. The longer the recovery phase after the acute polio illness takes, the more likely it seems that PPS will develop. This may be because a longer recovery will cause additional stress on the motor neurons. Neuronal low resources means more stress for the remaining neurons. Physical activity. If the patient performs physical activity to the point of exhaustion or fatigue, this may overload already stressed out motor neurons and increase the risk of PPS. Gender. Females are more likely to develop PPS. Complications regarding the post-polio syndrome. In general, PPS is rarely life-threatening, but severe muscle weakness and problems with various control centers in the brain can lead to complications. Falls. Weakness in leg muscles make it easier for polios to lose balance and fall. A fall may result in broken bones, such as hip fractures, or lead to other complications, i.e. muscle or sinew ruptures, etc. Malnutrition, dehydration and pneumonia. Polios who have had bulbar polio, which affects nerves leading to muscles involved in chewing and swallowing, often have difficulty with these activities, as well as other signs of PPS. Chewing and swallowing problems can lead to inadequate nutrition and to dehydration, as well as aspiration pneumonia, which is caused by inhaling, aspirating food particles or gastric acid into the lungs. Acute respiratory failure. Weakness in the diaphragm and chest muscles make it harder to take deep breaths and cough, that can ultimately lead to an accumulation of fluid and mucus in the lungs. Obesity, smoking, curvature of the spine, anesthesia, prolonged immobility and certain medicines can further decrease the breathing ability, possibly leading to acute respiratory failure. This is characterized by a sharp drop in blood oxygen levels or by a hyperventilation, and patient may require ventilation therapy. Osteoporosis. Prolonged inactivity and immobility are often accompanied by loss of bone density and osteoporosis in both genders. Polios may wish to be screened for osteoporosis. Possible therapies. The following individual therapies may be applied. Physical therapy on a neurological basis according to the Boberth therapy by Karol Boberth, Voiter therapy by Vaclav Voiter, Brankov therapy by Roswitha Brankov, or PNF therapy, proprioceptive neuromuscular facilitation, as well as classical massages, thermotherapy, traction sling table, logotherapy, ergotherapy, balneo bath therapy, according to Macmillan, also Stanger baths, pain therapy, respiration therapy, relaxation therapy, early aids such as crutches, orthesis, orthopedic shoes, electric wheelchair, and possibly social psychological consultation, etc. Most important, physical therapy on a neurophysiological basis, not to build muscles, but to retain what's left, passive. Cave, meaning to be careful with certain medicines. The following medicines are disagreeable with PPS patients and should be avoided whenever possible. Narcotics, muscle relaxants, psychoactive drugs, beta blockers, non-steroidal anti-rheumatic drugs, various antibiotics, aminoglycoside, tetracycline, gyrase inhibitors, and many more, fibrate drugs, antilipemics, statin drugs used to lower cholesterol, anti-allergica drugs, Novalgine. This doesn't mean they cannot be prescribed. On prescribing this particular group of medicines, the risks are to be weighed against their usefulness. When beginning a therapy with either of the above, the normal dose should be reduced to start with. Medications that help. Pain relievers such as aspirin, acetaminophen, Tylenol and others may ease muscle and joint pain. Numerous drugs, including pyridostigmine, mestinon, Regonol, amantadine, modafinil, Provigil, insulin-like growth factor, and alpha-2 recombinant interferon, have been studied as treatments for PPS, but no clear benefit has been found by any of them. The two-rule system should be applied for patients with PPS. The doses should be divided by 2. Post-operative artificial respiration should be carried out twice as long as normal. The post-operative recovery period is twice as long as normal. The battle against pain is twice as long as normal. The recovery period before hospital discharge, going home, or the walking ability must be calculated as twice as long as normal, as well as the time it takes to get back to normal, has to be calculated as twice as long as normal. The following problems that occur in a doctor-patient relationship, according to MD Peter Brower. The patient experiences a renewed deterioration of health state decades after the acute polio illness, partly with same and/or similar symptoms as with the initial illness. Can't find an illness-relevant explanation for the renewed deterioration of health state. Frequently has no knowledge of and about the post-polio syndrome. Reacts to the renewed deterioration of health state as with the initial polio illness by mobilizing muscle powers to overcome the weakness. On the search for diagnostic and therapeutic assistance is frequently met by embarrassment, ignorance, or even discrimination, especially if the patient is well informed about the illness. Uses little of his or her own capabilities for information acquisition, or none at all. Doesn't bother to support his or her physician actively with the information acquiesced. Found to be in a double subordinate position because illness and aid, i.e. physician, often decide on his or her life quality. Problems in doctor-patient relationship 2. The doctor is confronted with an illness for which a cause cannot be found using usual diagnostics, whereby the symptoms produce a number of other possible causes. According to the clinical picture, has to do with a patient with a high diagnostic expenditure, doesn't lead to a direct diagnosis, but to a diagnosis through exclusion. Finds effects of changes to patient that are changes conditional to age, primarily, and are secondarily to effects of polio and or late effects of polio PPS. He frequently tends to choose the first of the three aspects. Because of the difficulties in determining the cause of the uncharacteristic symptom complexity, reaches limit of his diagnostic and therapeutic possibilities. Rarely understands that the PPS patient primarily needs the diagnostic exclusion of other often well-treatable illnesses, which in many cases can be individually complex and occasionally require no further treatment. Extremely rare that he or she is confronted with the post-polio syndrome. Is unable to calculate the extent and process of the original polio illness, because he or she has to do with patients for whom, after many decades, no more access to the original patient documentation at the time of the acute polio infection is available. Confronted with patients where the anamnesis of the polio illness, due to an asymptomatic or abortive clinical course, is not verifiable, but who can nevertheless still be suffering from late effects of polio. Problems in doctor-patient relationship 3. The doctor is confronted by a disconcerted patient and, like him or herself, lacks specific knowledge. Thereby both doubt the credibility of a real somatic illness, or it can't be made plausible. Sees him or herself confronted with complete diagnoses delivered by informed patients that due to his or her own lack of knowledge and diagnostic possibilities, he or she finds reluctant to accept and mostly rejects as psychic, because he or she regards the making of a diagnosis as purely his or her responsibility. Finds him or herself in a situation of continuous indecision, whether further diagnostic measures in the form of a differential diagnosis and therapy from other medical specialists is necessary. Treats patients incorrectly because he or she can't differentiate between primary, secondary polio effects and the post-polio syndrome. Is limited to treating the patient therapeutically due to the thin balance between strain and overstrain. Has difficulties with the decision to prescribe a more or less therapeutically passive treatment for the patient from time to time, even when in the case of the post-polio syndrome this would be indicated. predominantly underestimates the magnitude of a significant mitigation for the patient. Confronted with the patient, he or she has to carefully explain the acceptance of the new mobility and capability limitations. Doesn't regard technical medicine, life-oriented and social help equally with medicines and physiotherapy. Problems in the doctor-patient relationship. 4. The doctor very often forgets his or her lifetime working obligation to keep his or her medical knowledge up to date without exception. Even knowledge that was published in 1875, forgotten, has then become relevant over 100 years later. Due to insufficient time, not able or not willing to obtain necessary information. Doesn't have it easy obtaining the necessary consolidated information on PPS, because the current relevant technical literature frequently ignores the topic. Seldom realizes or disregards the trait of thought of informing him or herself through the patient, or at least even asking the patient to assist. Often, but mostly unconsciously, sees his or her PPS perplexity, as does the patient, as a medical failure situation. In many cases, is unjustly afraid of losing his or her doctor-patient confidence bonus by declaring his or her diagnostic limits regarding PPS. On the other hand, is not afraid enough of the danger of prescribing the wrong treatment, leading to a therapeutic nihilism based on a wrong diagnosis. Is not willing to represent the patient's interests with sufficient emphasis in relation to health insurance companies and social agencies, due to lack of sufficient knowledge of PPS and time and budget reasons. Problems in the doctor-patient relationship. 5. The doctor. Due to the dependence of the patient in a doctor-patient relationship, has a position of power, which, for unknown reasons, can be used to the disadvantage of the patient. He or she harvests the fruits of his or her profession through the suffering he or she has caused his or her PPS patients in unawareness of the consequences by prescribing enormous rehabilitative psychological and physical training over many decades. A quotation by MD Peter Brower. The physician used to stand up for the polio patient. Nowadays, he or she stands in the patient's way. On patient symptomatic, it is important to remember that the patient may be suffering from a post-polio syndrome. Perhaps it may turn out that the patient is not a malingerer or is not suffering from fibromyalgia, but has the post-polio syndrome, which is handled entirely different. Appointment at the doctor's. Be prepared. 1. Your physician hasn't all the time in the world for you, so prepare a list of questions and have your own medical history list at hand should the doctor make reference to your past medical history. What could be the cause of your symptoms? Could there be any other causes? What tests will be needed, if any? What will they reveal, and what is involved in the tests? Is your condition temporary or chronic? What treatments are available, and which ones would the doctor recommend? Are there any alternatives to the initial approach the doctor advises? What about your other health problems, if any, and how can they be managed together? Do you have to follow activity restrictions? Will you become incapacitated? If you have informed yourself about PPS, ask your doctor if he has knowledge. Does he have brochures or any other material on PPS that he can give you, and what websites does he recommend? Appointment at the doctor's. Be prepared. 2. Be prepared for your physician's questions. Have you had poliomyelitis? If so, when? In which hospital were you at the time? How severe was the polio infection? Which parts of your body were affected by polio? Were you in the iron lung for treatment? What symptoms are you now experiencing? When did these symptoms first appear? Have the symptoms been continuous or occasional? What, if anything, improves your symptoms? What worsens your symptoms? What the patient can do. Having to deal with an illness from the past is indeed discouraging. What drive, suffering and determination to recover from polio was needed then, and now this, reliving it all over again. Here are some suggestions that may help. Limit all activities that cause pain and fatigue. Be moderate. Overdoing things on a good day can lead to several bad days. Use your brains. Conserve your energy through lifestyle modifications. Using assistive devices doesn't mean you're giving in to the illness. It means you've found a way to deal with it. Stay warm. Cold increases muscle fatigue. Keep it warm at home and dress in layers for the outside. Avoid falls. Carpets, rugs and loose things on the floor. Get rid of them. Wear appropriate shoes and avoid slippery surfaces. Adopt your living accommodation to your needs. Keep a healthy lifestyle by eating a balanced diet. Stop smoking and reduce caffeine. Breathe easier and sleep better. Protect your lungs. On breathing impairment, watch for signs of a developing respiratory infection, which can worsen your breathing. Have it treated as soon as possible. Avoid smoking and keep up to date with your influenza and pneumococcal vaccinations. Speak to your family and friends about your illness. Get support from your church or religious groups, social groups or clubs or organizations such as polio fellowships. Joining such support groups is a good way to start learning new ways of coping with PPS. Rest and relax. Find the right balance between activity and energy saving. Managing stress. Be aware and manage it. Accept offers of help. Do one thing at a time. Don't let things pile up. Know your own limits. Let off steam. Laughing is excellent. Be with people you like and who are positive. Practice deep breathing. Use relaxation methods. If you need mobility aids and orthotics, find out how to get them and then use them. Go on a health cure or to a special polio rehabilitation establishment or clinic. Here is a short list of some prominent persons affected by PPS. Our motto: together we're strong. It was said that you were most likely to die from bulbar polio, and if you survived, you made a better recovery than if you had spinal polio. Some of us had both spinal and bulbar. Einstein said, everything is energy, and that's all there is to it. It can be no other way. This is not philosophy, this is physics.